Hello, and welcome to this session. Again, this is for the Husson University RX 434 class, so everything I'm talking about will be oriented towards the role of the pharmacist. And in this session, we're going to talk about critical access hospitals specifically, and rural hospitals in general, as well as rural EMS. By the end of the session, you'll be able to define what a critical access hospital is, identify 3 challenges related to pharmacist practice in critical access hospitals and 3 solutions to these problems, and then identify 4 challenges for rural EMS services and relate each of these to concern around medications and the role of the pharmacist. So what is a critical access hospital? Well, it's not just a rural hospital. It's not just a hospital with low volume or with minimal resources. It's a specific designation from the Centers for Medicare and Medicaid Services, and it's for hospitals that serve rural areas that are either greater than 35 miles from another hospital, or if they're in mountainous terrain or there's only secondary roads greater than 15 miles. And the concept is that these are areas that are otherwise underserved by healthcare, and so these hospitals can serve as a gateway to healthcare. And to become a critical access hospital, you have to accept some limitations. You have to have less than 25 beds or less than or equal to 25 beds, have an average annual inpatient length of stay of less than 4 days, and you have to keep an emergency department open 24 hours a day, 7 days a week, 365 days a year. And that last part in some ways is the key to why a critical access hospital would exist. It's to guarantee that there's always an emergency gateway into healthcare beyond the EMS system. So when hospitals elect to become critical access hospitals, they actually get some benefits. So they can keep and treat common conditions, so things that they can routinely manage without expecting longer than a 4-day admission. They're welcome to keep them, treat them, and they'll receive cost-based reimbursement both on the inpatient and outpatient basis at 101% of reasonable costs. So as long as your costs are reasonably well controlled, you actually get paid for what you do, plus 1%. And if you own your own ambulance service, within some other restrictions, you can get cost-based ambulance reimbursement as well. And so those are all good benefits. So that lets a critical access hospital actually integrate what we could call critical access EMS as well. In addition, there's 101% of costs for training residents, so it's sort of a guaranteed 1% profit in a sense. 115% billing for surgical cases in which there's anesthesiologist training, and that's for the anesthesia. And then for physician services in areas that are designated as health professional shortage areas, they get a 10% bonus for the physician practice, or if the physicians reassign their billing, 115% times 100% of the professional fees reimbursement. So basically, this is a subsidy for keeping a hospital available in an area that otherwise would not have access to a hospital. So when we think about pharmacists and pharmacy management, you've got lower patient volume, and it's very hard to justify a full-time equivalent pharmacist. You're going to generally have lower medication turnover because you have less patients, so you need to maintain a smaller stock, which means that if you need more of a particular medication, you're not going to have it. And I encountered this when I went to a critical access hospital after a potential bat bite, that they did not actually stock as much rabies immune globulin as I needed, and I only got a partial dose initially. They also need to maintain a narrower range of options of medications because you are less likely to use more esoteric or less commonly used medications, and they're more likely to go out. So unless you're part of a healthcare system that is much larger and can rotate those medications in and out of your stock, you're typically going to have a more narrow range of medications. There's a lack of outpatient pharmacists in the community, so discharged patients, particularly discharged from the emergency department, may have limited access to prescription medications, and it may be a challenge for them to fill their prescriptions on an acute basis. Now, with the emphasis in mail order or mailed insurance company-based pharmaceutical distribution networks and systems for chronic medications, it's not such a big deal. Or if you have several days of knowing that someone's going to need a medication, it can be arranged. But discharging someone from the emergency department, they may not be able to fill their prescription for the first 24 hours. There's also a nationwide pharmacist shortage, and many of the locations where critical access hospitals are considered difficult to recruit to locations. And so it's difficult to get pharmacists to those locations as well. So that presents some opportunities. One of the major ones that's considered to be a pretty good option, and it's sort of across the board in health, is the idea of telepharmacy, where you have pharmacists available 24 hours a day in a larger institution who can provide remote pharmacy services, including controlling stock, either by overseeing the pharmacy stock or through actually remote controlled pharmacy carts. They can do order verification and assessment, particularly with clinician or computerized provider order entry. You really don't have to be at the hospital to be able to review the orders, and they can provide consultation services. Again, you don't have to be at the bedside to be able to make recommendations for, say, vancomycin dosing. You can talk about shared positions, either shared pharmacists between smaller hospitals or between a large hospital and a smaller hospital, and inpatient-outpatient pharmacists. So the same within a critical access hospital's local healthcare system, you may have a pharmacist that covers the inpatient side but also is responsible for your outpatient pharmacy needs and your primary care pharmacy needs and hospice needs, or any nursing homes, whatever might be affiliated. You can have a single pharmacist covering multiple venues. Formulary standardization is also very helpful, because if you have a large system that includes critical access hospitals, you can have a single pharmacist overseeing a large network because it's a single formulary. Therefore, you know what's available across the board, and there's no surprises or gaps when a pharmacist is covering a critical access hospital as part of their responsibility to a larger system. And then there's collaborative options. So can some pharmacist tasks be delegated? And not just to pharmacy techs, but are there other people who can do those jobs, the tasks that we would call a pharmacist's tasks? And so one of the areas where this comes up is one-to-one medication exchange for EMS. So a rural EMS service brings in a patient, they've used their medications, and under some interpretations of laws, and this will be discussed in the class where we talk about what's happened in Maine, the boards may determine that exchanging those medications is considered dispensing medications. Other boards may say that's not the case, and so you need to know what each licensing board says about those activities and where can some tasks that pharmacists would traditionally have to do be delegated to other licensees who are at those facilities. I, for the most part, dispense my own medications in the emergency department if I'm giving to-go medications. That's something that my license as a physician and my DEA certificate allows me to do, prescribe and dispense. And so in that sense, because I'm there 24 hours a day, or an ED physician is, that means that a pharmacist doesn't have to be there to dispense to-go medications. Now let's talk a little bit about rural EMS. And again, this is strictly from the pharmacist perspective, not a deep dive into rural EMS. So there's many challenges in rural EMS. Generally speaking, rural EMS services are lower volume, so the providers tend to have less experience, and not that there's lower reimbursement per patient, but there's lower total reimbursement because there's less patients. And so your fixed costs have to be distributed over a much smaller denominator of patients, and therefore your fixed costs per patient are much higher. And that includes stocking medications, particularly those you don't use. You've got longer transport times. So if you've got a 5 to 10 minute transport time, it's unlikely you're going to see the full natural history of a myocardial infarct unroll in front of you. On the other hand, there was an EMS service that I applied for a job for in southern Ohio where one of the medics who worked there was talking to me about what they did, and he said, this is the only place I've ever worked where we get to go through the entire ACLS algorithm twice, because our transport times to the nearest hospital are an hour and a half. And so we stock double drug boxes and just keep going. And because of that, you need larger medication stock to care for a patient over the length of that transport. You're relying on volunteers, so you're less likely to have paramedics, and you can have challenges in continuous staffing. There are counties in Maine where at night there may be one paramedic available to the entire county for 6 different services, and then those services function on a BLS level. I worked for a hospital-based paramedic response team in Pittsburgh where we backed up 8 services, many of whom originally had been BLS only, and over time evolved to either ALS all the time or ALS part of the time. And you're delivering patients to often community emergency departments or critical access hospitals, so they have a limited capability to care for the sickest patients, and you need to move patients on, so they may come in, get stabilized, and then the same EMS service has to transport them even further. You may have less experienced ED clinicians and nurses. So, for example, the Rural Trauma Team Development Program actually emphasizes integrating EMS into the resuscitation of trauma patients in the emergency department. And that's the reality of using the available trained hands that you have on deck. So there are a lot of challenges in rural EMS around in general and around medications. And pharmacists play a very valuable role in helping those EMS services make the best choices about what medications to use, how to stock them, how to work with the hospitals to exchange them, and can serve as advocates for broadening scopes of practice as well, and being able to provide safer alternatives to certain medications such that a lower license level may be able to administer them. So if there's any questions and you're in the class, we can cover them in class. Otherwise, feel free to post a question and I'll be happy to discuss.